Hi everyone. Thank you so much for investing your time with us. My name is Daivik and I'm a product marketing manager at Vigo Care, a remote patient monitoring company. Vigo Care has already associated with 100 plus doctors, monitor around 2000 plus patients for around 1 lakh plus hours. Today, we have an amazing panel for you to discuss on understanding remote patient monitoring, challenges and opportunities associated with it for healthcare providers and consumers, where we will be talking about the big trends we need to keep our eyes on, which will have direct impact on the healthcare. Our goal today is that whatever your role, you will leave with something that gives you better perspective about digital transformation of healthcare industry. So here is a format to give you an idea of what to expect. We will take a few minutes, briefly introduce our panelists and about their background in the industry. Great. Let's get started with the panel introductions. We have Dr. Shekhar, founder and CEO of Vigo Care. Shekhar is a maxillofacial surgeon by qualification and a serial entrepreneur by passion. He has over 18 years of experience in building scale organizations across healthcare and technology sectors. He is renowned for building A-plus teams and spearheading a wide spectrum of challenging business environments to build businesses grounds up. Introducing Shekhar as a moderator for the today's discussion and also would like him to share information about the company, industry, and the market challenges. We have next speaker in the panel, that is Dr. Srinivas. Dr. Srinivas is a senior consultant and HOD critical care medicine at Citizens Hospital, Hyderabad, India. He was instrumental in setting up electronic ICU and remote patient monitoring at Apollo hospitals and has very keen interest in use of technology for delivering critical care. He is a qualified teacher for India Society of Critical Care Medicine and DNB Critical Care. Dr. Srinivas has many national and international publications to his credit. He is also a member of Indian and European Society of Critical Care Medicine. Then we have Dr. Vijay Bhaskar. He has 20 years of experience in advanced pain management. He comes with a background of MBBS, FFP, MRCA, pain medicine, RCOA UK, CCT anesthesiology and pain management, neuromodulation and advanced pain research fellowship, London. I would like to hand over this session to Dr. Shekhar for further discussions. Thank you for giving this opportunity to introduce everyone, and I'm happy to have you here.
Thank you, David. Thank you for the intro. Good morning, folks. Thank you, Dr. Vijay Bhaskar and Dr. Srinivas for joining us here. Nowadays, healthcare sector as such is undergoing tremendous changes, and technology started playing a lot of role in delivering healthcare. We are talking about remote patient monitoring and telemedicine market growing at a CAGR of 31% right from 2020, which is much more than the projections and predictions that someone has done last year. So, and the COVID has propelled these kind of growth as well. And telemedicine is expected to be a $5.2 billion market in India itself by 2025. So it's big. But the point is, it's going to become big. But the point is, are we in the right direction? What are the actual use cases of remote patient monitoring? How do we really add value to the existing healthcare ecosystem is where the challenge is coming. And we will spend the next 20 to 25 minutes discussing those challenges and where we can really go and help the patients and doctors with the industry experts who are Dr. Srinivas and Dr. Vijay Bhaskar. Dr. Srinivas, I want to ask you one of the questions. You've been involved in setting up one of the largest remote patient monitoring setup and an electronic ICU setup a few years back in one of the largest hospitals. What was your experience, pros and cons? What were the challenges? I know you set up one unit and you probably did not scale from there. So what were the pros and cons? So can you share some experiences with us on that?
Yeah. Firstly, I thank Dr. Shekhar for having me here, and also Mr. David for your kind introduction. Yeah, thank you. And we have set up a electronic ICU monitoring system where the remote patient monitoring definitely helps decreases emergency conditions in the intensive care unit or into the remote patient area, and also and this happens in the real time monitoring, and there is a lot of decreased financial burden to the patient also, because and also there will be improved patient outcomes. Here we also can do education to the other side of the patient, where the remote area, so that their quality of care improves, and we can monitor large number of patients with the help of technology. Now my experience, this was almost 10 years back, where the technology is not very much developed. Still technology is at good level, not very advanced level, where we used to have a lot of manpower in the command center, and we used to have a much efficient manpower in the command center, and it used to be very difficult for us to monitor it. But I felt at that moment we are doing a great job, but with this remote monitoring in the command center and artificial intelligence with algorithms, I think that will decreases the burden on a doctors, that is all healthcare workers, and also the safety for the patient also will be. I feel that this is my experience.
So what you're saying is you had a lot of people to employ to monitor the patients, and you're saying if that people can be substituted by artificial intelligence, so that people can focus on what they really need.
Yes.
Do you think, did you attempt to take this outside the hospital and serving people outside the hospital? Was that system scalable outside the hospital? Was that limited only to the hospital?
No, it is much useful than within the hospital, where we are ours is a tertiary care center, where we have all trained specialists. But if you go into the outside the hospital or at the district level, where there is no much trained specialist, it is much useful at that center, because we can early identify them. We can use this type of monitoring system in the wards, in the ICUs and high dependency
What do you
units.
think, Dr. Srinivas, what do you think are the barriers to take this system to the masses, to smaller hospitals, to people outside the hospital? What do you think are the barriers?
Yeah, actually, frankly, we need to educate doctors more at the peripheries. So we need to educate the doctors more the advantages of this artificial intelligence, with these algorithms, and we need to show the outcomes to them, better outcomes. I think that only can improve our patient outcomes in the
Got it.
hospitals. Because they feel that most of the times they feel that we have a doctor, we have a nurse. Why do you need your monitoring system? They will monitor, but it's not possible. They go hourly or secondarily and monitor the patients. Okay, and here, if you use this system, this is a continuous monitoring system where the command center alerts the doctor or the nurse in their hospital, saying that, see, your patient is a downtrending, is becoming sick. Go and see the patient, so that your code blues decreases, okay, and also your patients crashing in the hospital decreases.
Got it. Thank you for those insights, Dr. Srinivas. Dr. Vijay Bhaskar, you worked for more than 15 years in UK, I think in fact 18 years in UK, and you were involved with the ICU setups, and being an anesthetist yourself, you probably were involved in managing critical care patients and even low acuity patients. What are your views on managing patients remotely? How do you think technology can help you manage patients remotely?
Thank you, Dr. Shekhar, and thanks for your nice introduction about me, Daivik. So yeah, so basically, if you're looking at it, any country, even if it is a developed country or a developing country, money always plays a role. You cannot have innumerable amount of staff, whatever you like. It's not possible. So the patients will come and you have to monitor. You have limited number of ICU beds. And we know that even during the COVID time, so we have limited number of ICU beds. So the patients have to be monitored probably on a ward setting or even worse at a home setting. So it's there. It's always there in a disaster situation. So you will require this kind of monitoring systems. And even patients who are stepping down from an ICU into a high dependency unit or further down onto the ward and making them to get discharged home, you will require some kind of a setup which has to be established. So for that, traditionally, we've been relying on a doctor-nurse relationship, and that was not fully functional. So about 20 years ago, we've developed what is called as the early warning scoring systems. And these early warning scoring systems, you're really relying on the nurse to actually document this. And on a busy ward where a nurse is looking after about 20 odd patients, and you can imagine how difficult it is to actually document it in a proper way, asking the nurse to document it. So when the early warning score is being done, and that has to be reviewed personally or physically by a nurse or a doctor to alert the next wrong specialist. Okay, so this has been a problem in any country there or even here. The problem compounds because, sorry to say, but then you will have the quality of the nurses to actually do all of these things who are already overburdened and undertrained.
So you're saying that if the early warning systems and the NHS scoring systems, if that could come into technology instead of nurses always monitoring it, that could be of a great use, is what you're saying.
Yeah, absolutely, absolutely right. Actually, what you require is some kind of an algorithm which is actually fitting into and then picking up the right candidate and alerting the doctor straight away. So traditionally, as I said, the ward nurses were unable to do it. So an ICU nurse who stepped down or walked out onto the wards was actually trying to pick up these things. And I've seen innumerable number of cases who are delayed in picking up.
Right.
Okay? I think something of this, an artificial intelligence kind of system, which is picking up patients quite in advance, and doctor gets all the trends to initiate the treatment, will be very valuable. And exactly the same thing, once the patient has got a surgery or even stepped down from an ICU, they need to be very carefully monitored. And so that is an advantage with this kind of a system that we're talking about. And there is a big role for technology to help the doctors. And Dr. Srinivas was telling doctors need to be educated first. Yes, they have to be educated not just in quality, it also has to be, or the outcomes. They also have to be educated that the care is actually enhanced and you will have more work to do rather than less work. And we should come out of the shell of this traditional medicine. I think that's what I would say.
Yeah, as long as you're getting early warning signs,
Correct.
And we can prevent human errors that could be cumbersome and burdening the nursing system, the technology can be of a lot of use, is what you are saying. Yeah, so I think all these things are very, very evident because of the COVID that has been in place for the last 6 to 7 months. And Dr. Srinivas, you've been running a COVID hospital, and then you probably treated a few hundreds of COVID patients in the last few months. What you think this kind of a technology, a remote patient monitoring systems or a telemedicine systems, what is your view? How are they going to help the current situation?
Actually, in the COVID scenario, a lot of patients were at home, and few patients were in the wards, and very few patients were in the ICU. So, in the lot of teleconsultations, video consultations were happening. But I think a continuous monitoring system of a remote patient monitoring at home will help these patients to admit early into the hospitals, because there is a lot of scarcity of beds in the hospitals. So we can easily guide them to the hospital when there is a trend towards the worsening of the patient, because these patients worsen very faster.
Right.
The lack of availability of bed. What we can do is, in this type of patients, the how stable they are, we can do a 6-minute walk test for these patients, and we can see the trend of this monitoring, and we can suggest them whether these patients are fit to be at home or they can be admitted to hospitals. Actually, now there is, in COVID hospitals itself, the patients are more, the healthcare workers are less. I think every patient admitting to the hospital should have a remote patient monitoring, because this trend not only from the hospital, from the home, we can see in the hospital itself, and we can shift these patients to the ICU early, so that to avoid disasters in the wards.
So you're saying we can triage the patients into the hospital, is what you're saying.
Yes.
Do you think it also helps in any way post recovery, post discharge monitoring? Do you see any correlation for application of remote patient monitoring into post discharge monitoring?
So some of the patients, of various reasons, we are discharging these patients, post-COVID ICU or hospital patients, to the home on home oxygen therapy, and with a minimal oxygen, because these patients require a lot of days of stay, and some patients, due to permanent changes in the lung, they need oxygen therapy for months. So this is one of the monitoring which helps them. A doctor can monitor from home,
Right.
so that not only the financial burden on a patient decreases, also the hospital acquired infections also decreases for these patients,
Right.
so that the outcomes are better.
Yeah. Do you see patients who got discharged relapsing their disease and then coming back? Is there any way that we can use technology to prevent those kind of readmissions?
Yeah, we had a few patients who were coming back and having a readmissions in our hospital, who we have treated, again coming with breathlessness. And these patients were in a very far area. Few patients came from very far area, and we used to have video consultations. So during these video consultations, I could assess them at that point of time for that few minutes, but I don't know what is the trend happening to their vitals during the last 24 hours.
Right.
That was a setback for me during the video consultations. I think this remote monitoring setting, like having heart rate, respiratory rate, blood pressure, SpO2, and temperature, these monitoring given as a trend, that will help us much.
Understood. Dr. Vijay, coming back to you, I'm sorry to hear that your entire family went through COVID yourself. And Dr. Vijay was mentioning to me, he had 50% of his lungs totally soaked in pneumonia. and he was tested COVID positive, and he went through the entire cycle himself, and entire family went through the cycle. Sir, I want to. What did you feel? Did you think if there is some technology, uh, would you have felt more safer? How do you think something could have helped? Just not traditional vitals alone. Is there any way technology could have helped you more?
Whether we like it or not, as doctors and the hospital owners, the patients have already started doing that themselves. They have taken the burden upon themselves. They've invested on a pulse oximeter. They've invested on a temperature probe, blood pressure, and they started doing it. And we are actually lagging in terms of providing them a better platform. Already patients have done it, and many social organizations, they've already started doing it. So I think it's a high time we also step up the game and then give it a better structure. And there is absolutely no doubt, as you asked, my whole family was affected, and I was trying to monitor each of them, and it was quite difficult, which is how I got affected. If I had the luxury of having a good monitoring system, a remote monitoring system, I wouldn't have got affected in the first place. So that's the answer to the whole thing. I was the last one in the family to get affected, and because of the viral load, I had a bigger kind of volume of my lung affected because of that, and it took longer for me to recover. All these things could have been reduced. Maybe I would have had it, or maybe the disease would have been less severe. So yeah, I mean, definitely in terms of having through the course of the disease, if you have it monitored very well, almost like 80 to 85% of patients would not require any hospital care, and a few percentage, maybe about 10% of them will be on a ward care. All of these could be monitored very nicely with a remote monitoring system. Very small percentage of patients would go to ICU anyway, which would be a very expensive care. But again, once the disease is gone, the COVID is gone, but then you will have, for example, a macrophage, a cytokine storm, a mass, what we call macrophage activation syndrome. So these kind of things, when they happen, you will require some kind of monitoring. These things can happen a little while later. It's not the first 2 weeks or 3 weeks when you can have the patient admitted into the hospital, but there is a very protracted recovery phase, late pulmonary phase, where you can have pulmonary scarring, and the patient can have a long rehabilitation period. And all of these can be, to a certain degree, they can be managed at home safely if you have a monitoring system again. And your exercise capacity can be built up over a period of time when you have a monitoring system like this. And you can liaise with your physiotherapist, you can liaise with your, I mean, not only the doctor, what I'm talking about is the therapist. And they can also have the data, and based on that, they can suggest you. They don't have to come to you. I think there is a lot of role for this to play, I would imagine.
Do you think integrating systems like spirometers, electron spirometers, which can probably measure lung capacity, and do you think any role of such kind of devices that can be integrated into the remote patient monitoring platform?
Yeah, you have rightly mentioned. So there are certain things that are essential. For example, their walking ability. Dr. Srinivas was mentioning about the 6-minute walk, which was traditionally done. And in anesthesia, we were trying to get the patient how many flights of stairs they were climbing. So this was a very traditional way of monitoring. But with the advanced systems that we have, you can actually get the total number of steps that the patient has taken over a day, or maybe how much he could run, or maybe all these kind of systems, and particularly the respirometer, which is very essential. So these are all other things that could be integrated. Yeah, definitely.
Yeah, understood. I think I see the challenge is probably 15% of the patients need hospitalization. But the challenge is how do we identify those right 15%, right? So that they are identified early. And what is clearly coming out is that's where the technology has to play a role in identifying the 15% and triaging them to the higher centers for further treatments. Yeah. I want to ask Dr. Srinivas a question. You've been running a critical care unit in Citizens Hospital and seeing varied patients who have been critically ill. Where else do you see the role of technology for you? Where else do you see the role of remote patient monitoring, not just ICU monitoring, remote patient monitoring for you?
Yeah. Before that, I would like to mention on 2 points. One is on incentive spirometry. You mentioned that.
Right.
Actually, in the initially when the disease is severe, they can't even breathe in. Okay, so the lung volumes are very low. One of the good parameter where when the lung volumes are measured, that the disease is recovering better. These are functional things. It's very difficult to identify radiologically by doing a CT scans whether the patient is improving or not. Spirometry is one of the very good equipment to know us that a patient disease is improving. One. Second thing, as Dr. Vijay Bhaskar was mentioning, that the pulse oximeter, most of them are using pulse oximeter and temperature and blood pressure. So with the pulse oximeter, the waveform is not in a very good way. Okay, if the waveform is not good, the value you cannot read it. That patient doesn't know, which is a good waveform or a bad waveform. I think that our remote patient monitoring will help us. The only sensitive parameter which is useful is a SpO2 and respiratory rate. Respiratory rate again is difficult to count. When counting your own respiratory rate, you will be very conscious. Either you breathe faster or you breathe slow. Okay. So these are the two parameters, important parameters for triaging our patients. I think you will fail in identifying these, triaging these patients if you are doing it in a self manner. I think remote monitoring helps in this.
One more thing, if I may add, actually.
Yeah, please.
You are actually using a pulse oximeter. Most of the patients may not be aware that the first thing you put a pulse oximeter on, the reading that you get is an erroneous reading. Okay, you'll have to keep it for about 20 to 30 seconds so that it gets the right reading. Okay, yes. Many a time what you find is you put the pulse oximeter on, you get a 99%, but then slowly it will start to dip and then it will stabilize at probably a 94 or a 95. But the patient will always take the 99 as reading, and then he might tell the doctor that he has got a 99. But something like this, a system, exactly. Once you have a system which is actually taking a reading over a period of time, it will give a better reading.
Yes. Right. Which means technology should help the patient to eliminate all these errors and noises and be able to carve out the clean data for the consumption of the doctor.
Correct. Yeah. And that's what the technology should do, rather than making the doctor work harder. And if these things, as you say, the right word, noises, if they are reduced, and then if a technology comes to a level that it is more easier for the doctor, or maybe the time is reduced for processing the data. There's a lot of data. If it can be reduced and the final tidbits are given to me, I think as a doctor, I would feel very happy to use the system.
Understood. Dr. Srinivas, coming back to the question, where all do you think remote patient monitoring could help other than the COVID? Do you think technology role is only for COVID or even otherwise?
Yeah. See, actually, now we are in a COVID era, so we are more talking about COVID patients. But we can use in the ICU, non-ICU conditions like high dependency units, post-operative units, the wards, and the good part about the technology is you can use this in any part of the world. You can set up a hospital in a tribal area and you can monitor them. So these are the advantages. One, so the trends in suppose I give an example of a post-operative patient. A post-operative patient who has underwent abdominal surgery, he might be bleeding inside. He looks normal. His blood pressure maybe in the little downtrend, but he has a tachycardia. Okay, and the blood pressure, urine output decrease, and his blood pressure slowly drops. So if you see into the trends, heart rate is rising, blood pressure is slowly coming down. This alerts you that this patient is having something wrong. Probably fresh post-operative patient bleeding is happening.
Right.
So these type of things, we can introduce the differential diagnosis in the algorithm itself, and it can give you one checklist, one sepsis, two bleeding. Like this, it can introduce, and it makes the doctors also to think more about the patient differential diagnosis and treat as soon as possible. I think every setting it is useful, non-ICU setting.
So you're saying whenever the patient is needing less acuity monitoring, it brings more data to the doctor to be able to make the right decisions and early decisions and triage them back to the
Yes.
hospital. So what is your view on video consultation, especially Dr. Vijay Bhaskar? This is a question to you. In a clinical setting as a private practitioner, you might be doing a lot of video consultations with the patients, and there is a lot of video consultations out there. So what's been your experience? Do you think that is enough, or is there anything more that is needed for you to consult with the patient? What's your experience there?
The first thing with the video consultation, we are traditionally used to do a live consultation with the patient, and we are trained and taught and groomed in a way that you start observing the patient as they're walking into your clinic, and the way they sit down, the way they talk, all of these things, they do matter a lot for a clinician to arrive at a diagnosis. And then, of course, the vitals that are recorded before they come in, and the investigations that we give. This is how we are all groomed to. But suddenly in a video consultation, you've got a small camera, probably poor in its pixels, and then you only have got a patient's face to see. It just suddenly gets very difficult to arrive at a diagnosis without the complete physical examination. The clinical examination part is out of the window, and to arrive at a diagnosis, I'm always afraid that I might miss something, because a part of my examination is gone and my feel of the patient is reduced. So at that point, at least, I wouldn't make a real seriously sick patient, and I wouldn't treat that patient on a video consultation. I insist on them coming into my clinic. But for a moderate to severe patient, say for example, even during the COVID times, a moderately sick patient, I would be rather more happier if I have more data points, if I have more information about the patient, about the vitals, and more importantly, the trends of the vitals. If I have those, I will be a bit more confident in advising the patient to stay at home or come into the hospital. At
Right.
least I'll be happy in that sense.
You're not having enough of data to make
Correct.
decisions for them, is what you're saying. Yeah. So which means that just to summarize what we've been speaking, what I hear from Dr. Srinivas and Dr. Vijay Bhaskar is there is a tremendous use of remote patient monitoring in bringing in efficiencies and early warnings into the healthcare ecosystem, especially helping the doctors focus on what they are doing and give enough of data for them to make decisions for their patients. So one is a continuous monitoring, the other one is it's going to help as a triaging system and a early warning system. And probably in cases of COVID, Dr. Vijay Bhaskar would have got saved of COVID if there was a remote patient monitoring and he didn't need to go to his family to check vitals continuously. So that's how remote patient monitoring could help. And a little bit about what we are doing at Vigo. We have developed a connected care platform where we are connecting on one side doctors and hospitals, and on the other side the patients, and we transmit vital data from one end to the other end, and we use algorithms and we follow the EWS scoring system and new scoring system from NHS to produce early warnings and then triage the patients. And it has been very heartening in the last few months to see patients being monitored and COVID patients being triaged to the hospitals. But listening to you, both of you, it tells us that we as a healthcare technology company and many other people in India and globally from healthcare technology, we need to do a lot more to be able to really benefit the doctors to serve their patients. And I'm happy to having both of you here along with us. And we are on a mission to take